Okay, good morning, everyone online. And if any of you have joined online and are here in person, we do have the room today, so we are in person. Feel free to come and join us because we have a lot of muffins and coffee here today. Um, so I'll start with the land acknowledgement. We are built, Ottawa is built on the unceded Algonquin and Anishinaabe territory, and the people of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land, as well as all First Nations, Inuit, and Métis people. Our presenter today is Dr. Kate Remick, who is an associate professor in the departments of pediatrics and surgery, and associate chair for quality innovation and outreach, co-director for National EMS for Children's Innovation Improvement Center, the Dell Medical School at University of Texas. That's all at the Dell Medical School at the University of Texas at Austin. She's not the Dell Medical School. And the medical director for the San Marcos Hayes County EMS systems. So I thought I would just read out those titles because they give a sense of the system reach of the work that Kate's doing. She's a founding member of the Global Pediatric Readiness Network, a multinational group of healthcare leaders working collaboratively to establish pediatric readiness as a global standard. Her work transects policy development, survey design, advocacy, health system transformation, and the creation of data visualization platforms and registries to ensure system-level readiness and ultimately high-quality emergency care for children. So her title, that's all context. I thought that was relevant for her presentation and the title, which is a case for global pediatric readiness and emergency care. So yeah, thanks for joining us.
Thank you so much. Good morning. Thank you all for joining online. Thank you all for joining in person. Nice to see you. It's really wonderful to be here, and particularly in May when you have all the tulips blossoming. So thanks so much for inviting me to speak to you all. Just a couple disclosures, which is just related to grant funding, and nothing I say is the official views of either of these funding entities. As I show the objectives up on the screen, I just wanted to share a little bit of background about how I got into this work. So when I was a chief resident at St. Louis Children's Hospital in Missouri, we did not have a transfer center as part of our hospital. And as chief residents, we rotated every third night as running our transfer center. And we would receive phone calls from hospitals and emergency departments, not just all over the state of Missouri, but also across multiple state lines. And we got a little bit of a window into how emergency care systems are set up. There were oftentimes children that were in relatively small emergency departments, maybe 4-bed emergency departments with epidural hematomas, patients who were bleeding with platelet counts of 0, patients who maybe were at risk for abuse, but it went unrecognized. And really just getting some insight into how our emergency care system was set up was a very unique experience for me. And I suspect that many of you in training have been to some of these other more remote areas or regions of the country, and you've seen these low-resourced areas. But what I found and what I think was most astounding to me is that these weren't necessarily low-resource communities. This was happening in metropolitan cities. This was happening in everyday communities where children live and grow up and establish themselves as contributors to our society. And over the last really 30 to 60 years, we have seen a real transformation in our healthcare systems where we've gone from just having emergency care services and healthcare services available to really focusing on quality. We see this with regionalized systems of care like trauma systems. We see this with stroke systems and cardiac STEMI systems. But largely, pediatric patients have been excluded from the quality framework. And we really don't have a standardized way of saying, are our emergency care systems really ready for children? And unfortunately, A lot of this comes down to ratios. In the world, children account for about 30% of the overall population. But in a single emergency department, they generally represent only about 20 to 25% of all patients that come into the ED. So there is a misconception by the great majority of physicians and nurses and healthcare staff who are working in emergency departments that children don't come here. But this is false. And in fact, over 80% of children are seen in emergency departments that do not specifically focus on pediatric patients. And this is where we really have a problem, where you have EDs that think all we take care of is adults, and yet, in fact, collectively, that is where the great majority of children are seen. And so as pediatricians, as advocates for children, as healthcare administrators, I think it's really important that we're advocating for how our emergency care systems are ready for kids. And this is particularly important too because, as you all know, our emergency care systems were designed to do more than just now manage emergencies. Now they're being used regularly for essential primary care health services. They're being used for public health surveillance. They're being utilized for regionalized systems of care, and they're also being utilized for disaster response. So we really need to start thinking about how are these systems ready to take care of pediatric patients. And I would say, and there's many examples of this, and this is but one by Gabby Frere, who's at Toronto and Sick Kids, where she was looking at low value imaging among a variety of hospitals across Canada. And this is true everywhere. Again, this is just reflective of emergency care systems and healthcare systems really globally. But what you'll see is that there are significant differences in what percent of children receive unnecessary imaging based on the type of hospital that children go to. So whether it's a community hospital or academic hospital or truly a pediatric or children's hospital, there are significant differences in variability in care. And this is probably not surprising to most of you. And I guess the point that I really want to make here, though, is that it's not because the physicians or nurses in these facilities are not smart enough or don't know enough about taking care of children. It's about designing our systems to be able to provide the right infrastructure, support, and resources to be able to manage these children appropriately. If you look at most adult EDs, it's become very protocolized. We have protocols for managing postpartum hemorrhage, managing chest pain, managing neurodeficits and the potential for acute stroke. But in many EDs, we lack regular utilization of protocols, order entry sets, physician support tools, et cetera, to really help to standardize care. And this variability in practice, unfortunately, impacts patient outcomes. It was shocking to me when I first read this study by Sri Ramgopal, where he looked at pediatric visits in hospital emergency departments and found that only half of children have a complete set of vital signs. That should be astounding to you when we think about how are we actually managing pediatric patients in these settings. And as many of you probably know, there's enormous inaccuracies when it comes to pediatric triage, even following whether it's whichever triage tool you use, the Canadian triage tool or ESI or whatever the triage tool is that is used, there is very poor adherence to the actual rules around pediatric triage. And in some studies, we see about a 50% rate of over and or under triage, which would not be acceptable in most of our trauma systems, right? Where, we usually in trauma systems, we accept maybe 10 or 15% over or under triage, but to have a 50% is just really, a very poor representation. And in the US, this is now public knowledge, unfortunately. In fact, many of our large media outlets have gotten wind of the fact that our emergency departments really are not ready for children. And these are a few of the publications that have come out over the last decade, some of these just in the last couple of years. But children are dying in ill-prepared emergency departments across America. Many hospital ERs aren't ready to treat children. And yes, this is maybe a little bit dramatic, but in fact is true. And if we are really relying on just our healthcare staff to take care of patients. If we're saying this is a human issue, then we are going to fail. In 1999, 2000, the Institute of Medicine in the United States published this report, To Err Is Human, which suggests that we as humans make errors in our everyday practice, as we know, and therefore rely on systems to be able to help ensure that we don't falter. This is the report that first disclosed that, at least in the United States, there are probably 90,000 people who are dying of preventable medical errors alone. We know children in particular are at much higher risk of medical errors because weight-based dosing, developmental needs, differences in physiology and anatomy that impact the types of diseases and conditions they see, the ability to communicate effectively about their signs or symptoms. And since this report, as many of you probably also know, there were subsequent reports that suggested that the number of people dying from preventable medical errors alone was probably on the order of about 150,000 people per year in the United States. And right before COVID, it became the third leading cause of death in the United States, was noted to be preventable medical errors alone. And I'm talking about death, not even morbidity. So if you add that in, it's really tremendous, and we really need to be thinking about how do we design our systems to be able to be more effective in ensuring that we as healthcare providers who have worked hard, trained hard, can do our best and provide the best care. Because you can take the best physicians in the world and put them in a very low resource, low prepared situation, and they will fumble and they will perform poorly. This has been recognized now for, as I said, over 30 years. There are now standards for pediatric readiness, which is making sure emergency departments are ready to meet the needs of children, that have been published around the world. In the US, in Australasia, in the UK, the International Federation for Emergency Medicine, and also in Latin America. And all of these standards were published really with a shared vision, shared recognition that outcomes for children depend entirely on the reliability of the system. And if we could adopt these standards in all of our emergency care systems, we would likely be able to achieve much better outcomes for the pediatric population. So I want to just define pediatric readiness, because unless you live in this world, you may not understand what I'm talking about when I'm talking about system readiness. So system readiness is about ensuring that the equipment and supplies are available, readily available, and well organized. I have been shocked to find that in many emergency departments I go into, the first thing I ask for is, where is your resuscitation card for children? And sometimes I find that it's a locked bag in a charge nurse's office, and if the charge nurse is there, the key's not available. Or sometimes I find that it's a bag that's back in a corner of a room that has to be dusted off. When you open the bag, you find there's expired equipment, expired supplies. It's difficult to really sort through it. Sometimes there's not weight-based or length-based dosing tapes. Sometimes it's very difficult to figure out how to identify what is the right equipment or supply that I need to be able to manage this child. Pediatric and medication safety is really dependent on having drug dosing formularies available, so we take off the cognitive load. It's also about making sure we're not over-imaging children when it comes to taking care of them. Policies, procedures, and protocols, and I will say that Canada is really quite ahead, and I'll talk about this in a minute, but having pediatric-specific policies, protocols, and procedures that we're following on a standardized, regular basis. How are we appropriately, again, triaging children, or how are we managing asthma, or how are we managing head trauma, and those sorts of things. We can't assess the quality of care that we're delivering in any single emergency department if we don't have a quality improvement plan and process. And this is beyond just chart reviews. It's not just pulling a chart and saying, okay, this was an adverse event or a sentinel event or a death, and we want to review the chart and see what went wrong. It's actually about tracking some of the more foundational processes of care every day. So are we getting full sets of vital signs? Are we doing pain assessments? Are we reassessing mental status in the case of head trauma? Are we appropriately treating seizures, active seizures when they come in? Are we using the appropriate dosing and regimens and timeliness, et cetera? And that is continuous quality improvement. We do this all the time in stroke. We do this all the time in trauma. We do this all the time in heart attacks. but we don't do it regularly in the pediatric population. And this is a problem because people aren't thinking about children. And if we don't give them a reason to look at the care, then there's a reason to falter every single day, every single time. Support services, of course, social services, laboratory services, mental health services, and things of that nature. Not all hospitals have access to this. We don't necessarily have resources to have licensed mental health professionals in every emergency department, but even having case managers who can help sort through some of the needs and follow-up care. And then lastly, of course, maintaining competencies. So how do I make sure that I'm regularly comfortable with managing children? And a lot of folks are turning to simulation-based modalities to help support and improve that comfort level. And in order to have this sort of system-level readiness in place, there must be someone to oversee it. Again, we do this in trauma, stroke, STEMI centers. We have stroke coordinators, we have trauma coordinators, and we must have pediatric emergency care coordinators who are making sure that all of these things are in place. They need not be full-time positions, but someone has to be assigned the responsibility of ensuring that all of these things are actually in place in the emergency department so that we can do our best when it comes to caring for children. And unfortunately, in the United States, despite 30 plus years of work, our median score in terms of overall pediatric readiness across the country is 69.5. So at best, we're getting a D plus right now in the US in terms of improving care for children. So why should you care about this in your given roles? And I will tell you that we now know that this does actually impact mortality in children. So this is really was pretty astounding when some of these papers first started coming out right around the COVID era. First one was by Stephanie Ames in 2019. And as many of you probably know, the mortality rates for children who come to the emergency department is generally low, generally less than about 1%. So if you start to see a reduction in mortality because of system-level readiness, then that really suggests a significant impact in terms of overall care. So this was a study where she looked at about 425 emergency departments across 5 states in the United States, and she looked at critically ill and injured children who came into the emergency department and divided these emergency departments based on quartile of pediatric readiness. So the lowest quartile of readiness and the highest quartile of readiness. And she looked at mortality rates for those children. And what she found was that children who presented to emergency departments with high levels of pediatric readiness had about a 76% risk reduction in terms of overall mortality. That's huge. Subsequent studies, yeah, go ahead.
Where do you see the reduction in mortality at the low end of the readiness score? And if you can repeat the question, because people don't.
Yeah, so there was a question about why don't we see this reduction in mortality at the lower ends of the readiness score? And that's because many of these emergency departments had very few pediatric patients and very few deaths, so the confidence intervals are very wide. So we had in some of these EDs, they had just, one death, so you either have 100% survival or 100% deaths, and that's why we really don't see this benefit until you start to see higher volumes of care. So thanks for that question. This was another study by Craig Newgard and colleagues. He really established the Pediatric Readiness Study Group in the US, and this was looking at 830 trauma centers across the United States and looking at outcomes for critically injured children. And again, looking at the various quartiles of readiness, we found that those patients that are in the highest quartile of readiness have a significant overall reduction in mortality. And most importantly, I think here, is that those who are in the third and second quartiles of readiness, you don't see the same survival benefit. So it's not a stepwise approach, but it's actually a threshold level approach in terms of overall readiness and survival. And in this study, he showed that over 750 lives could have been saved over this 6-year time period if all of those emergency departments had been pediatric ready. One of the other, I think, really important studies that has come out of this too is looking at, well, what is the time to death? Maybe we can't make every emergency department pediatric ready, so maybe if we just allow them to do the work that they're doing within the resources they have, and then we transfer these patients out as quickly as possible to children's hospitals or pediatric academic centers, then maybe it would be just fine. But what he found in this study is that the median time to death for pediatric patients who succumb to their injury is about 3.1 hours. And I don't know what transfer times look like here in Canada exactly, but in the United States, the average transfer time is at least 2 hours from arrival in the ED, and more often on the order of 3, 4, or 5 hours after arrival to the ED, for a variety of reasons, not the least of which is many of these individuals are spending the first few hours really just trying to stabilize or intervene in the care of these children. And what this study really shows is that we don't have enough time to rely on transfer, particularly when you look at large distances. If the majority of children are dying within the first few hours of arrival to the ED, then we must act immediately, and we must have the resources immediately available to be able to resuscitate these children and stabilize them before transfer, not after transfer. And then yet another study looking at not just short-term survival, but actually long-term survival out to 1 year in children who presented to emergency departments with high versus low pediatric readiness. This was a study looking at all emergency departments, 980 emergency departments, not just trauma centers, and looking at both critically ill and critically injured children, and finding significant differences only in that highest quartile of readiness. So again, a threshold level of survival benefit, which in this study was 88 on a 100-point scale. Other studies have been done, again, and I'm showing this because it's very compelling, like study after study of the impact of pediatric readiness on survival. But this was one looking at the National Trauma Data Bank and looking at survival from mortality risk from pediatric readiness. And you'll see right around 90 as a pediatric readiness score shows a clear reduction in mortality risk, again, with these higher volume centers. And then among pediatric trauma centers, the benefit is even greater as you score higher and higher on the pediatric readiness scale. And we have seen for years that survival in pediatric trauma centers compared to mixed or adult level trauma centers is much better. And I speculate it's primarily because of levels of pediatric readiness. So every second really does count. And what we have found in the United States, based on this data, I mean, we have 30 million children presenting to emergency departments, so we're fortunate to have large volumes of pediatric patients that we can really look at, the impact of pediatric readiness. And we have found that nearly a third of deaths are truly preventable if we could make every emergency department pediatric ready. This is really the last study that I'll show, again, just looking at pediatric readiness, but this study in particular was using the 2021 pediatric readiness assessment and just verified, again, that being in that fourth quartile makes a huge difference in overall readiness. We did try to look into, are there certain components of pediatric readiness that are more important than others? Because some emergency departments have come to us and said, well, if we can't do it all, are there certain things that we should focus on? And so we plotted out observed to expected mortality rates across 550 trauma centers in the United States and looked at those with the highest survival rates and tried to say which of those components of pediatric readiness are more present in this group than in other groups. And we found initially in a univariable analysis that pediatric triage, comprehensive quality improvement, disaster plans, and critical airway and resuscitation equipment, not surprisingly, are most important. But unfortunately, none of these actually panned out in multivariable regression, suggesting that it is the entire complement of pediatric readiness that's important, not just one single piece. And that makes sense because we don't know exactly why children are going to present to RED, whether it's because of an airway obstruction or a hemorrhagic shock or some other condition altogether. So what I'd like to also share are some studies that have been done globally, because we're starting to see a community across the world that's beginning to look at pediatric readiness and recognizing the importance of it. And this was one of the first studies that was done outside of the U.S. looking at outcomes related to pediatric readiness. It was done in Latvia, and they looked at hospitals in the entire country, all of which transferred to a single children's hospital. So they looked at pediatric patients who present to these EDs and are then transferred to the children's hospital. And what they found is that those children who presented to high pediatric readiness EDs or higher pediatric readiness EDs had lower ICU lengths of stays, lower overall hospital lengths of stays, and similar to the other findings, lower mortality rates. So now we're starting to look at patient-centered outcomes related to hospitalization and also potential value-based care, because when you look at cost of hospitalization, impact on families and the like. Now, overall, you can see that the weighted pediatric readiness score in Latvia is quite low, so lots of opportunities for improvement there. And some of the biggest gaps, as you'll notice, are related to both quality improvement, as we were just talking about in the last study around individual components, and then also, of course, related to coordination of care, where there's some really significant challenges and competencies. Recognizing the gaps in pediatric readiness, we did our first national assessment back in 2003 in the United States, looking at pediatric readiness. And since then, we've really tried to work hard to make this not a mandate, but instead to really support emergency departments and hospitals to become pediatric ready, because we know that there are a lot of strains on the healthcare system broadly. So over the last 20 years, we've worked really hard to not just have the national standards or guidelines, but self-assessments that hospitals can use to determine their current level of pediatric readiness. We have a checklist that hospitals can use to go into the ED and say, do we have all of these things, and actually check it off. And then we now also have a toolkit with hundreds of resources that are available for pediatric readiness. So I'd like to now just transition to sharing kind of what is the current state of pediatric readiness around the globe, so you can see kind of what is happening in terms of overall pediatric readiness. We really have approached this as a national quality improvement initiative in the United States. So, if you're doing quality improvement in an emergency department setting, you might be doing rapid cycles of improvement, perhaps every few weeks, or maybe even every week or every month. In the United States, when you're doing a national effort, we're looking at every 5 to 10 years, we're looking at reassessment. So it's a much slower period to really move all of our hospitals in the United States around this effort. We have about 6,000 hospitals in the US, so it's quite a large ship to steer in terms of managing that. In Canada, I believe you all have around 700 hospitals, just to kind of put it into perspective in terms of overall numbers. So the National Peds Ready project is really based on these national standards or guidelines that were developed initially in 1993 and have evolved over time. In 2001, it was a joint effort with the American College of Emergency Physicians and the American Academy of Pediatrics. In 2009, we added in the Emergency Nurses Association, and most recently in 2026, we added in the American College of Surgeons Committee on Trauma, because frankly, the American College of Surgeons, seeing all this data on mortality for injured patients and being, one of the things that we're most proud of in the U.S., our trauma system is, very robust, and to see how we're failing this particular population in whom injury remains the leading cause of death is something that they had to act upon. And so now the American College of Surgeons is one of the key partners in the National Pediatric Readiness Project. And as I said, we're not really proud of our numbers. We have a lot of work to do. In 2003, we only had a 30% response rate. This was just before everything went digitized, right? So these were truly mail-out surveys. You can imagine how successful that would be now, right? If you get something in the mail, you're not going to fill out the survey. But 30% of hospitals in the U.S. Participated in 2003, average score 55. The great majority had no idea that national standards or guidelines even existed. So that was the first problem. Like, how do we even get the word out that we should have system level readiness? 2013, much better. We actually had an 83% response rate, which is pretty incredible. So over 4,000 hospitals participated. Score came up. And then in the midst of COVID, not an ideal time to be testing for pediatric readiness when our whole healthcare system was so strained. Many nurses were furloughed. There was a lot of repurposing of people and staff. The median score had only come up to 70 or 69.5. We actually have a pediatric readiness assessment underway right now. We only have about 4 more days left. We do about a 3-month period where we launch the assessment. And this is where we're at right now, about 70% response rate in the US or 3,900 hospitals. What we found over time is that there are really 2 primary drivers of pediatric readiness that are modifiable. One is having a pediatric emergency care coordinator, which is associated with an average adjusted 16-point increase in overall pediatric readiness. Meaning, if we remove the points on the assessment that are associated with the PEC and normalize the remaining scores, we see an average 16-point increase in overall readiness. Similarly, we see that in a number of upcoming studies and those that have come out, that having PECs is also associated with increased adherence to evidence-based practices, decreased head CT utilization, decreased chest X-ray utilization in asthma, and also higher resuscitative performance. So in addition to higher pediatric readiness, we also see better adherence to evidence-based practices. The second thing is quality improvement, as I mentioned. If you're not looking at the quality of care provided, how can you say with any certainty whether the care that's being provided to children is good or not? And we see that those EDs that have a full quality improvement plan is associated with an average adjusted 25-point increase in overall readiness. Again, if you remove the points associated with quality improvement, normalize the remaining scores, this has the potential to propel an emergency department from the lowest quartile of readiness to the highest quartile of readiness, imparting a significant survival benefit. What we found in the United States is that there are some significant barriers to quality improvement that we've been working hard to address, and I'll share some of those. But some of them are this fact that most EDs see low volumes of pediatric patients, so if you're going to engage in quality improvement, choosing things like sepsis and DKA are not necessarily meaningful and actionable for most of these EDs. Instead, things like respiratory distress, head trauma, seizures, these are the things that most emergency departments care about because those are the common types of conditions that we see in most EDs. We also knew it was really important to have people, to have standardized quality measures, and to have technologies in place that could support many of these emergency departments. So within our toolkit, we've now created kind of a journey map or a roadmap, you might say, to helping people to become pediatric ready and to sustain it over time. And this is just an example of what that looks like, of really taking the national assessment, seeing where your gaps are, identifying a champion or pediatric emergency care to start improvement efforts, and moving forward. These are what we've used as our drivers for pediatric readiness. So the national self-assessment, which people can take anytime. Yes, we have national assessments about every 5 years, but individuals can go in and take this national Peds Ready assessment anytime in between so that they can continue to do local quality improvement. We also have the toolkit and checklist that I mentioned. We host a number of large-scale quality improvement collaboratives. So those of you who are familiar with the Institute for Healthcare Improvement or other models, we use the Breakthrough Series model to host quality improvement collaboratives to help guide nurses and physicians in implementing pediatric quality improvement efforts and improving Peds readiness. We now have a national web-based platform for quality improvement where hospitals can look at standardized quality measures and begin to benchmark their performance on foundational critical processes of care. I'll show you that. And in many states, and now also the American College of Surgeons and the American College of Emergency Physicians have integrated pediatric readiness standards into their verification programs for trauma center verification, for ED accreditation, and just for pediatric recognition in states. So knowing that Peds emergency care coordinators and quality improvement are the primary drivers, we've developed pediatric emergency care coordinator modules to help train people, standardize education to really support pediatric emergency care coordinators. It's pretty simple. These are about 10 to 15 minute modules that they can take. They get a certificate, and we're trying to really push towards standardization of the PEC role and ideally certification in the coming years. This is what the National Peds Ready Quality Initiative data platform looks like that we've developed. So hospitals who enroll, they log in. We now have about 350 hospitals across the US that have started enrolling in this. We just opened a few years ago. But when they log in, they get to see what other hospitals are participating just broadly across the states, not name, but okay, there's 24 hospitals in Kentucky or this many hospitals in different places, and they can see kind of the breakdown of the demographics. And then in addition, they can choose any different common condition to work on. So these are the conditions, the clinical bundles that we've integrated into this data platform. So they can focus just on pediatric patient assessment, getting vital signs and pain assessments, or they can focus on things like suicide screening or interfacility transfers and optimizing those transfers out, dehydration, vomiting, etc. These are examples of the measures that we've worked on. So we worked with about 25 national professional organizations, regulatory bodies, and federal entities to come up with 28 quality measures across these 7 conditions that have now been fully vetted and integrated into this national quality improvement data platform, so that hospitals now have access to real-time performance data for all patients that they enter into the system. And this is what their dashboards look like. So there are table views and there's graphical views. And as an example, if they were working on assessment bundle, they might see this and they'll say, oh gosh, you know, in terms of pediatric pain assessment, our performance is only 54% of pediatric patients are having pain assessed in our emergency department, compared to our national average of 79%, and similar like hospitals, a cohort performance of 78%. So this is really something that we in our emergency department can work on, and then that allows them to really drive their improvement efforts over time in terms of that. And what we also offer are graphical views. So this is what the graphical views look like. So as they implement various intervention strategies like staff education, physician support tools, standing orders and triage, et cetera, they can actually drive their improvement over time and see how their efforts are paying off in terms of overall care for children. And really these measures were chosen because they're the basis for many of our critical illnesses, whether it's, you know, recognition of shock or, you know, recognition of sepsis, having full sets of vital signs and alerts and the like in place. So these are really chosen with the hope that we can optimize performance not just for all patients, but specifically for critically ill or injured patients. Did you have a question? No. Okay. And so as I mentioned, we now have the integration of pediatric readiness into these standards across the board, which is really exciting. So I wanted to share more than just the US, obviously, and I wanted to share some studies across Canada as well. So there have been really 3 studies that have happened across Canada, both in Alberta, Manitoba, and then of course here in Ontario. The one in Ontario was primarily run through the Provincial Council for Maternal Child Health, but has done significant amounts, you know, of work. The first study done in Alberta had about a 60% response rate, which is great. Lots of opportunities in terms of the role of pediatric emergency care coordinators and quality improvement plans. Only about 8% of all those hospitals had a PEC, and 5% had a pediatric quality improvement plan in place. The median score was 48. The next study in Manitoba, 67% response rate, which is great. Most of these EDs were fairly low volume, about 4,000 visits per year, so not high volume EDs, with a median score of 52. And then most recently in Ontario, 40% response rate, highly representing the Ontario Health West group, representing 60% of respondents, so a little bit of a bias there, but the median pediatric readiness score of 63. So this kind of shows you how are we doing currently in Canada. And you know, this was more specifically in the Manitoba study, lots of opportunities, you know, specifically in the areas of coordination of pediatric care, staff competencies, and then quality improvement were really the biggest areas of need. This is again the Ontario study, just a little bit more of a breakdown. You know, there's a significant interest, particularly in mental health. So the initial assessment The Peds Ready score, the 63%, was based on the National Peds Ready assessment that we created in the US. But then they also added a mental health score to this because there was a real heavy interest in improving mental health care here in Ontario. And the average or median mental health score was 57%. I think, what has been really impressive about the work in Canada has been so much of the work that's come out of TREC with creating evidence-based guidelines, which in this assessment are very widely used, which is fantastic. This is a huge boon, I think, for Canada. And generally speaking, most EDs in Ontario had the great majority of equipment, but similar to what we found in the United States, the most commonly missing items are airway equipment, which is problematic, and then also, chest tube insertion kits and things like that. So just really thinking about how can we really target some of our focus. But what you'll see is 29% of academic health, non-pediatric, I should say, hospitals have a PEC in Ontario. 64% of hospitals require pediatric competencies for nursing staff. Only about 42% of hospitals reported having a quality improvement plan in place, and the majority of those was simply chart review. So there is significant variation in adoption of any kind of pediatric indicators or quality measures to really drive performance. And then you can see some of these others. Only 21% of hospitals include children in their disaster plan. And this is really important because we never know when disasters are going to happen. And if you're not thinking about the pediatric population, there are a lot of opportunities for improvement here. I think it's really exciting that Canada is getting very organized around pediatric readiness. As some of you know, there's now the checklist as well for pediatric readiness. There's the survey, and when you take the survey, you get a hospital-specific report, which is really helpful to see how you're doing. And so many resources with TREC, of course, which is phenomenal. And I know that Gabby Friere out of Toronto is working on a mixed method study to launch pediatric readiness nationally across Canada with colleagues all across the various provinces to really look at pediatric readiness in the coming year. She has planned focus groups and implementing the national assessment here. In addition, Lynn Moore at Laval has done some really tremendous work in creating standardized quality measures, primarily focusing on pediatric trauma, but I think this is a really important start for how do we begin to look at standardized measures for pediatric care in emergency departments. And some of these are pretty simple, so these came from her studies, head CT within 60 minutes for children with a Glasgow Coma score of less than 13, documentation of full sets of vital signs, following head CT guidelines for low-risk head trauma, stabilization of femur fractures, and then some of these more advanced intracranial pressure monitoring and nutritional support. But some of these are very relevant to low-volume EDs, community-based EDs, where we see head trauma, we see critically ill and injured patients. This was a multinational study done in Europe by the REPEN group, so the Research in European Pediatric Emergency Medicine group, and they sent out a survey to 21 countries. They got 101 EDs to respond. This is really a bias study because it's looking at individuals who participate in research, and then they sent out to 5 to 10 other EDs. These are obviously EDs they work with closely. But what they found was that only about a quarter of all of those EDs had over 80% of the recommendations in the IFEM standards, the International Federation of Emergency Medicine. So really some huge opportunities here in terms of management, pain assessment being one of those, but you can see the breakdown of standards fulfilled. In Denmark, they looked at 13 EDs and 3 trauma centers, and they found a median pediatric readiness score of 70, about similar to what we have in the US, slightly higher for trauma centers. And what they found was most important was having availability of a pediatrician on site. Many countries don't have pediatric emergency medicine as a subspecialty yet, and even those that do, there are many physicians who aren't actually participating. So it represents a very small minority, and so many EDs, even in countries with peds emergency medicine subspecialty, are not staffed with peds emergency medicine physicians. In Greece, one of the biggest problems is simply comfort level with pediatric patients. And many of the staff in these EDs are generalists or even pathologists or surgeons. They're not necessarily people who have experience in emergency medicine or pediatric emergency care. And I was shocked to learn that less than 5% of physicians in Greek emergency departments even had PALS training or PALS certification. So this is really problematic when, if you're thinking about a beautiful trip to Greece and you're taking your children with you, these are important things to know, because when we have an emergency, we go to a hospital that says emergency department because we anticipate that they can handle emergencies. And what we're finding over and over again is this is unfortunately not the case. In Lebanon, they also looked at this. About 2/3 of hospitals even had one policy on pediatric patients. It would be wonderful if TREC were globally used. All of these evidence-based practice guidelines that exist, why don't we have them available, around the world or for everyone? Only 50% of Lebanese EDs had formal pediatric triage. Many were lacking transfer guidelines. Less than 50% had transfer guidelines if they didn't have a pediatric ICU. And lots of equipment that wasn't available. Yeah. Oh, 5 minutes. Okay. Similarly, in Central America, lots of opportunities for improvement in terms of equipment and basics of supplies. And this was done in pediatric EDs, not general EDs. So even just looking at, this was looking at 17 countries in Central and South America. And then in South Africa, work especially looking at even essential equipment. And now there's work across the African continent really looking at national assessments that are in line with the IFIM standards. So there really are now multinational efforts to promote pediatric readiness, some that are becoming more and more organized, more and more formalized, and these are but some of those and when they launched, which I think is really exciting to see. And this is what brings me really to kind of the final comments of my talk, which is that we're really now moving towards building a global pediatric readiness network, because we realize that this is not just a unique issue to the United States or to Canada or to North America, but truly is an issue broadly across the world. And a European health report said child mortality is an important indicator of a population's overall health status and access to essential health interventions. And it's these inequities in healthcare access and quality that remain obstacles to closing the gap between high and low income countries. So this is our Global Pediatric Readiness Network now. We just launched in the last year. We have countries from all over the world participating. Here in Canada, a number of participants. Terry Clausen from Saskatchewan, Leah Crockett, Gabby Freire, Lynn Moore, a number of others who I mentioned whose works I cited in this presentation. But we hope to be growing, and we hope to have representation from really every country around the globe as we drive both national and international efforts. And our goal is really to coordinate so that we're not all reinventing the wheel, but are really sharing tools and resources. So we've developed a charter, and these are our core objectives, really looking at the various standards and trying to move towards a single set of global standards for low, medium, and high resourced areas, not necessarily countries, because even in a given country that might be considered a high economic country, we have very low resourced areas. And so it's really about the individual site, not about necessarily the country as a whole. We're really hoping to work towards a global pediatric readiness assessment tool so we can begin to track pediatric readiness on a worldwide basis and look at how that is impacting survival over time. We are also beginning to pool together all of these resources so that they can be shared and readily available. We'll be working to establish a global PEDS readiness research agenda. And lastly, and perhaps most importantly, is continuing to advocate for universal adoption of pediatric readiness standards, both within our own EDs and within our region, within our states or provinces, and within our countries. So I think that's all I have. Thank you.
Thanks, Kate. That was a wonderful talk.
Thank you.
I was taking notes on questions as a draft email, I accidentally deleted it.
Oh, no.
Which kind of annoys me, but yes, okay, we already have a few people online. I will give Mala the first question in the room, and I may ask my questions afterwards. Yeah.
Okay, it was a very impressive talk, Kate. Thank you very much. And it's a really remarkable program that you built. And from what I understand, pediatric readiness encompasses both the readiness with equipment, but also readiness to deal with conditions. Our ED here does a tremendous amount of ED outreach to other emergency departments in our region. Some see higher volumes of children and some see much lower volumes. I'm just wondering if what your thoughts are around the emergency departments that see lower volumes of children. No matter how much ED outreach is done or teaching, it's very difficult for those healthcare providers to provide competent pediatric care to children with high stakes, low frequency conditions. And so instead, have you guys, I'm sure you have thought of this, but tell me your thoughts around maybe concentrating pediatric readiness in the moment on higher volume sites and providing actually in the moment care with an experienced pediatric emergency physician to those lower volume sites where you need the equipment, but you may not necessarily be able to count on the knowledge at the time.
Yeah. So the question, so the question was about outreach from pediatric academic centers to other emergency departments, recognizing that low volume EDs are a particular challenge due to comfort level. Higher volume EDs, maybe should we be focusing on them, and what's the opportunity to provide direct consultation during these high risk, low frequency events? Yeah, I would say that education wanes. And it's also very difficult to hit every single provider on a regular basis. And so it has to be about system infrastructure. It's not just equipment and supplies, but it's having protocols and order sets and integrating it into EMRs. And yes, having the training. Can you have benefit from a direct one-to-one consultation? Sure, but that is not going to overcome deficiencies in having a color-coordinated resuscitation card, a length-based tape to measure the weight of that patient, the competencies of placing an airway, an advanced airway in a pediatric patient in distress. So yes, it can help in terms of perhaps supporting as a coach or a consultant in the care of a major resuscitation of things to think about, but it's not going to overcome every single pediatric patient challenge that presents to them. So I think there should be pediatric outreach from children's hospitals and to these community sites, because I think we have a responsibility to share our knowledge and our resources and our tools, and we're seeing that. But it helps more to actually go into those EDs and make sure that they're set up so that those physicians and nurses can be most effective in understanding their own resources rather than having to make that phone call every time. Yeah, hopefully that answers the question.
Yeah, thanks. I think we'll go to Jamie next and then to Amy.
I think Amy was first before me.
Okay, I'm going on the order I see on the screen, but Amy, why don't you go ahead?
Sure, just excellent, very interesting work. And, I think congratulations, especially on the Big Pern project, looking at global readiness. I was looking at the responses to the survey from the PCMCH in Ontario, and asking people for, even as a first step, do you actually have the equipment? And, if the first step is getting people to fill out the survey, and only 40% of all the hospitals in Ontario do, like, how do you do that? Like, for me, I feel like almost there needs to be a punitive thing. You don't fill it out, we're provincially funded. So how does one address that if people won't even answer the questions?
The way that we were most successful in getting people to participate was through our professional societies. Because they have a lot of influence. And so if the emails had just come out from me or Marion Gaucher-Hill or some of the other leaders in pediatric readiness, I think they would have been ignored. But when the American Academy of Pediatrics and the American College of Emergency Physicians and the Emergency Nurses Association and the American College of Surgeons are all coordinating a response to say, pediatric readiness is important, you should participate. It is a constant communication and marketing strategy to bring awareness around pediatric readiness. And our first assessment, you can say maybe the response rate was poor because it was a mail out survey, but I think poor because nobody knew about pediatric readiness or what it meant. So part of the first step is really just building awareness.
So maybe in Canada, CAPE is that's our Canadian Association of Emergency Physicians, which I think represents a lot of people outside of the pediatric center. Maybe I'm not sure where they are in pediatric readiness, but very interesting. Thank you.
Thanks.
Thanks. Yeah, Jamie, go ahead.
Yeah, thanks very much, Katherine. That's a very important work. I'm just wondering, in terms of contrasting with Canadian data, do you have mortality and my mortality data? And my comment is really about a lot of the data was from the US, is that in Canada, for example, in Ontario, we have these very well organized transport systems for adults and children. So, for example, in Ontario, we have one number to call so that there's a critical care physician online right away when the doctor anywhere can phone to get a transport, and then they end up coming, if they're critically ill, directly to the ICUs. And then during transport, the very advanced paramedics are talking with either a critical care doc or an emergency doc. So it's a very different system. So I was just wondering if you do have mortality data. That's the first question. I may be running out of time, but my second question I'll get to.
Yeah, unfortunately, we don't have mortality data in Canada, but I would very much encourage researchers in Canada to begin looking at this because I think it's really important. Many countries simply don't have the volume of pediatric patients to do the mortality analysis, although shockingly in Latvia, they did even see a difference in terms of mortality. So I think you certainly have sufficient numbers where Canada could begin to look at this pediatric readiness and outcomes from critical illness or injury. Yeah.
Yeah, so Jamie, I think we are going to go to the next questions, but I see you're in your office, so if you want to come and scrum right after, you're welcome to walk over. So Ty, we'll go to you, quick question, and Melissa, quick question, then we'll draw it to a close.
Hi, Kate. So I'm an emergency physician and trauma team leader, and one of the hats I wear at CHEO is actually the director for our outreach program through the emergency department. So I'm definitely one of the choir members to whom you're preaching, and I appreciate this work. My specific question is, I think, in my own experience, one of the biggest challenges is, as you've laid out, the importance of the PEC, the care coordinator, that there aren't enough, that it's probably not incentivized well enough, and it's hard to retain. And there's just a lot of turnover in these smaller community departments. So in the US experience, do you have any strategies, or what are you guys doing to try and improve this? Because I think it's a universal problem.
Yeah, one piece is that the Emergency Nurses Association in the US just established a resolution by their members to appoint a pediatric emergency care coordinator in every ED. So again, do not underestimate the role of professional societies and advocating through them because I think that's huge. Secondly, it does not need to be a full-time role. So assigning it to, sometimes it's the trauma manager or a charge nurse, or especially in these EDs where one person often has many roles. And so just making sure this is at least defined within their role, because in most EDs, it's just not even defined. It doesn't exist. But what we have found, to your point, is that if it is a volunteer position, there's going to be a high turnover rate. And so it really needs to be integrated into the organizational chart of the institution. And I think one of the best approaches is talking with physician leaders, hospital administrators, and speaking to them about risk management issues. And maybe that goes back to Ty's question about mortality. So you can certainly cite US data and Latvia data around mortality. But if you need Canadian data to be more compelling, then I would really encourage that work to be done here in the near future.
Thanks.
Yeah, thank you. And I think we will wrap it up. I see, Melissa, you are going to reach out offline. Perfect.
Okay.
So thank you again.
Thank you.
That was
all
an
so
outstanding
much
talk.
for
There's Jamie, and thanks again for coming up
Thank
here
you.
and visiting.
Thank you. Thanks for the opportunity. Lovely to be here.
Yeah. know, it's not popping up for me, oh, there it is. You zoom in.